So, that's sort of a history of how we got to where we are today. But, where are we really? Where do we stand today? Have we moved the needle in complications? Well, this is a recent study from the NSQIP, which is a National Surgical Quality Improvement Program that includes, patients who had surgery in the United States. This database included 11,000 patients, over 11,000 patients who had surgery from 2006 to 2018. This includes, smaller hospitals, not necessarily academic centers. So the length of stay went down from 10 to 8 days, not necessarily 4 days everywhere. But complication rates we were able to see a significant decrease from over 50% to just at about 50%. The major complication rates, however, were unchanged. Readmissions are unchanged, specifically urinary tract infections and sepsis, which is severe infection, remaining prevalent after the operation at about 9%. So why are we able to improve some things but not everything? I think it requires us to take a look at the literature, the studies that have been reported, and get a better understanding of how we are implementing ERAS protocols. And if we're not implementing them all the way, then why not? So this was a study put out a couple years ago that looked at all of the studies on ERAS and how did they report and use all of those 22 measures that we talked about a couple of slides ago. And what they found was, after they searched the whole literature, they found 48 published series that reported on an average of 16 of the 22 steps, meaning 6 of the steps were never even mentioned in most of the studies. The adherence to the steps that were mentioned was about 80%, which does make sense. You can't do every single one of these interventions in every patient, and these pathways do have to be personalized. But we would still like it to be closer to 100%. And I think that we need to understand, what might be holding us back from that. Another nice study that looked at, variations or heterogeneity of implementation of ERAS pathways was this study that looked at the association between antibiotic prophylaxis, which is preventative antibiotics before cystectomy, and at the time of stent removal, which is the stents that connect the kidneys to the urinary diversion, and infectious complications. This was another systematic review that looked at all published studies and included 20 studies of 55,000 patients. They found that the rate of any infection after cystectomy was 40%, urinary tract infection 20%, and bacteremia, which is a significant infection in the bloodstream, was 6%. What was important in this study was that there was very heterogeneous or diverse use of antibiotics, and duration of antibiotics, and time of stent removal. On this figure here, you can see that this red line is the duration that patients were on antibiotics, preventative antibiotics. So at the top line here, you can see that antibiotics were given continuously for 30 days, and some studies here just gave it for 24 hours right after surgery, and they didn't continue this long dose of antibiotics. These blue triangles here are showing the time that the stents were removed from the urinary diversion. So you can see that it's all over the place. So, though we are all doing our best to take care of patients, everyone has a different method, a different protocol. And really best practice comes when we're all aligned and we have a good understanding of, what really is best care for patients. Since those guidelines were published in 2013, we have had a lot of evidence come into the field that has influenced our ability to make recommendations for patients for what we think is best. In 2013, the guidelines identified 804 studies in ERAS and included 11 of them in their guideline report. And when they synthesized or put all the data together, they saw that the evidence level was low for 21 of those recommendations. So a lot of the recommendation was just expert opinion. Again, as I said, I'm very fortunate to be part of a group of really impressive, physicians from all different backgrounds, nurses, nutritionists who are updating these guidelines. And in our most recent update, we identified over 3,000 studies, including 182 clinical trials, which clinical trials we generally think are a higher level of evidence than just retrospective reports where people are just talking about their experience. So the evidence level today is better, but I will admit to you that it's not perfect, even though perfection is what we are always going for. So how do we use the existing data to improve outcomes moving forward, and how do we get better data to improve outcomes moving forward? Well, I think that one of the most important things is that we develop more evidence-based measures, meaning we have more study to understand if things are truly better. We need to be away from all of the dogmatic practice. In the past, like I said, everyone would get an NG tube. No one would eat until they passed gas, and no one would get out of bed after surgery. Bed rest was the dogma at the time. We need more evidence-based measures to eliminate dogma from our perioperative care. Also, we need to look at outcomes beyond the index admission. In our survey, you all stated that the rate of any complication is the most important outcome after surgery. And I agree with you that it's an extremely important outcome. But we need to look at other things, including late complications, readmissions, costs, and I think more and more important every day is getting a better understanding of the patient experience as reported by the patient, not by us physicians. To really be honest about things, we need to understand how our interventions affect you. So this is just a short list, not a comprehensive list of recently completed or ongoing clinical trials in ERAS, specifically for radical cystectomy. This list shows that it is possible to do clinical trials in surgery and to really try to get the best evidence possible for our patients. If you look here, you can see that a lot of these trials are centered around something called prehabilitation, education, and a lot of trials here on nutrition. So what is prehabilitation, and how does nutrition play a role? Well, prehabilitation is essentially, the most simple way to think about it is exercise before surgery to try to improve your fitness for surgery. And in order to understand who is going to benefit from that, we need to have an ability to preoperatively assess functional status or fitness before surgery. If we're able to do that, we can intervene. You can see here, this red line is sort of, where we were before the widespread use of prehabilitation or recommendation of exercise before surgery. In the early preoperative period, patients are at a certain level of fitness. When you have surgery, there is inherently a hit. This is a stressor, and you have to recover. So there is a period of recovery in the postoperative period. And as I showed in one of my first slides, patients do get back to a baseline level of function and quality of life, but it can take 2 months, and that's just the honest truth. 6 to 8 weeks is what you should expect in your recovery. But there's a lot of research, and there's people doing things now to try to improve your recovery. If you do prehabilitation before surgery or exercise, or do special nutrition supplements, things like immunonutrition, you can improve that level of fitness so that there's a gap, so that when the time comes for surgery, you're at a higher level of fitness. When that inherent drop comes, you can have a faster recovery and get back to a higher level of functional recovery after surgery. So that's really, prehabilitation, preoperative nutrition, and sort of in a nutshell. Another important outcome that I think up until recently we have sort of not been giving enough attention to is the importance of mental health in the patient experience. So patients with bladder cancer have disproportionately high rates of depression and anxiety. Depression rates can be up to 23% before treatment and 71% after treatment, and anxiety can go up to 78% after treatment. We do know from retrospective series looking back at how patients did that preoperative mental health is associated with your risk of developing a high-grade complication after cystectomy. And again, I think it's very healthy and good that we're talking about this more and more in society as a whole. But individuals with cancer, including those with bladder cancer, are at a 2 times increased risk of death from suicide compared to the general population. So these, mental health risk factors for depression, anxiety, and suicidal ideation need to be screened before surgery. And if identified, patients should see a specialist, either whether that be a mental health specialist, a psychiatrist, or whatnot. But it's not something that should be ignored. And as competent surgeons, as Professor Ledbetter urged back in 1950, I want it to be clear that this is something that we think about and we make sure is addressed in our patients who are undergoing surgery for bladder cancer. Now, everything I've talked about so far has been recovery after radical cystectomy, because that is the more complex and major operation that we perform. However, recovery after TURBT has been overlooked, neglected, and it shouldn't be, because this is the most common procedure done, most common surgical procedure in bladder cancer. Over 100,000 transurethral resections are performed in the United States each year, and patients do experience things like ED visits. They have pain, they have hematuria or blood in the urine, and they can have issues with their catheters that require them to come to the ED or come back to clinic. The rates of all these things are not nearly as well studied or reported as the rate of complications after cystectomy. So just as that paper in 2009 sort of sobered us to the challenges in recovery after cystectomy, I think that we're being honest in looking at these outcomes after TURBT and think about how we can improve the patient experience. And ERAS is certainly a way that we can improve the patient experience. ERAS, standardized pathways, have been used for other endoscopic surgeries. For example, in kidney stone surgery, using an enhanced recovery after surgery protocol decreased the use of postoperative opioid use, narcotics like Percocet, Vicodin, Oxycontin, decreased from 93% to 0% in one study. In another study of endoscopic surgery for benign prostate disease, ERAS protocols were able to lead to earlier catheter removals and better pain control. I wanted to give a well-deserved shout out to one of my friends and colleagues, Max Cates, for initiating the effort in ERAS after TURBT in an ongoing clinical trial called Embrace. And you can see in these 3 groups here, it's not too dissimilar from the guidelines for cystectomy. There are a lot of preoperative, intraoperative, and postoperative measures that can be done to enhance recovery after transurethral resection, whether that's just better counseling and education of how to care for a catheter at home. Avoiding fasting before a TURBT could be just as important as before cystectomy. Standardizing anesthesia protocols during TURBT, using non-narcotic pain medicines, and then other things to make the catheter care, if needed, a little bit more comfortable after transurethral resection. So this is ongoing work, and I think that we're going to see a lot more study in this in the future. So with all of these efforts going on for ERAS and all of the new data coming out, how do we ensure that we're implementing these to the best of our ability to improve outcomes for our patients? Well, the society guidelines, I think, are important in my biased opinion, as I said, being able to be involved in the development of these guidelines, but these guidelines do represent best practice. It doesn't mean that every single measure has to be performed, but they provide a checklist that's essential for execution of a care plan that can very oftentimes be very complex, and coordination among multiple different treatment teams is needed. It's not just the urologist, urologic oncologist taking care of these patients. It's the nurses, it's the anesthesiologist, the physical therapist, the nutritionist. So having a checklist helps everyone stay on the same page. These checklists do not replace expertise or responsibility, but the existence of checklists and existing care pathways really facilitate the conversation amongst all the stakeholders to improve care for patients. And one very important stakeholder is the patients themselves. And that's why the patient-reported outcomes, I think, are going to be essential to look at moving forward. This is just an example of how we, have created checklists to try to improve outcomes at my institution. We make it readily available to patients. These may be a little bit outdated at this point, but this is an example of a flyer that, we give to patients. This is a checklist that patients get before surgery and after surgery to sort of keep track of what's happening with us in their care journey. And this, I'm very happy to see up on the wall in our hospital unit at the hospital. These are laminated posters that we put on the wall of every patient who's had cystectomy. But you can see that cystectomy is just one of the operations that has an ERAS checklist. We've got colectomy here, gastrectomy, pancreatectomy, hepatectomy. So it's not unique to patients undergoing bladder cancer to want to enhance recovery after surgery, but radical cystectomy, transurethral resection of bladder tumor, these are very unique procedures, and we should have unique and dedicated care pathways. So I think my most important take-home points are, that bladder cancer is an aggressive malignancy requiring aggressive therapy. I think we've done Professor Ledbetter proud in moving that cure rate to almost 100%. We're doing a great job there, but transurethral resection of bladder tumor and radical cystectomy are still essential treatment modalities in patients with bladder cancer. Not every patient needs cystectomy. Every patient does need TURBT. We're able to preserve quality of life with meticulous surgeries, appropriate selection of urinary diversions, but challenges in recovery do exist. Perioperative care pathways, ERAS, has revolutionized the patient recovery and the patient experience after surgery. They're well accepted, but implementation is inconsistent. But I think that continued multidisciplinary collaboration will result in further improvement, both in the implementation of these pathways, but in the recovery of patients with bladder cancer. So I'll stop there. I really look forward to, hearing what questions you guys might have and to having a little back and forth.